All right, our next talk is going to be on opportunities as a physician advisor, and we're very pleased to have Dr. Lisa Varghese Kroll as our presenter. Dr. Kroll is a physician advisor and appeals specialist with MedMetrics. She has over 13 years of experience as a physician advisor, is board certified in physical medicine and rehabilitation, and is an active writer and public speaker. Dr. Varghese Kroll has unique experience, a unique background in journalism with a separate degree as well as experience in both print and broadcast media. She is also the co-host of the health and parenting podcast, Health and Home with Hippocratic Hosts, which is listened to on 6 continents. And I had to count. I think the only one we're missing is Antarctica, there, doctor. She received her MD from the University of Virginia Medical School of Medicine, and her BS in broadcast journalism from Virginia Commonwealth. And she is a Sikh alumna from a few years back. Welcome back, Lisa. Thank you so much.
Thanks so much, Jim. Appreciate that intro. And hello to everyone. Good morning, good afternoon, good evening, wherever you may be. I'm very happy to be here to talk about physician advising. And for those of you who might know a little bit about it, or for those of you who have never heard anything about it, I'm hoping that this will serve as a primer and a bit of a deep dive into this very exciting specialty. So the best place to start is always the start. So what is a physician advisor? So a physician advisor acts as a liaison between a hospital's clinical physicians and their utilization review team. What does a physician advisor do? Well, this is by far not a comprehensive list, but some of the tasks that might fall onto a physician advisor's plate include helping the medical staff achieve medical necessity compliance and improving their documentation, helping the UR team understand the reasons for the clinical physician's decisions on each case and their unique perspective. A physician advisor might provide status recommendations and write appeals. They educate staff on documentation requirements and policy changes. They can serve as a point of contact for payers, completing peer-to-peer discussions or formulating appeals and discussing those with them. And they can serve as an expert witness in administrative law judge hearings before Medicare judges. In a nutshell, a physician advisor takes a major responsibility off the plate of their clinical physician peers while ensuring that that critical role is still filled for the hospital. So what is medical necessity compliance? Well, essentially, it's a complex process that aims to ensure that each patient is treated in the appropriate admission setting and according to evidence-based standards of care. So why does it matter so much? Well, CMS, the Centers for Medicare and Medicaid Services, develop conditions of participation and conditions for coverage that hospitals must meet in order to participate in and be reimbursed by the Medicare and Medicaid programs. And while these standards are intended to improve quality and protect the safety of patient beneficiaries, they were also implemented in order to drive accountability and compliance and to recover reimbursement on previous claims that had admission statuses incorrectly submitted. And the Code of Federal Regulations states that hospitals must have in effect a UR plan that provides for review of services furnished by the institution and members of their medical staff to patients who are entitled to benefits under the Medicare and Medicaid programs. So we live in an auditing environment. That's the reality of the world we're in today. And ever since 2004, which is when Condition Code 44 was introduced, CMS has moved towards using the concept of medical necessity to recoup dollars. And Condition Code 44 allows inpatient orders to be changed to observation or outpatient orders before a patient's discharge if it's determined that that's what's appropriate. And from 2005 to 2008, the RAC demonstration project was underway. RACs are recovery audit contractors. They're independent contractors who are authorized by CMS to audit hospitals and to keep a portion of the money that they recoup. So that project was a huge success from CMS's perspective, and RACs now exist in all 50 states. Physician advisors are the ones who play a very important role, not only in hospitals' process for handling their interactions with RACs, but also their processes for interacting with private payers. So what are some of the things that a physician advisor might be consulted for? Again, this is not a comprehensive list, but at the top of any list would have to be inpatient versus observation stays. which admission status is most appropriate for each patient. They might be consulted on the medical necessity of outpatient procedures, on CFR compliance for specialty services such as inpatient rehab, inpatient psych, SNFs. They might be asked to provide the medical rationale for coding cases. And it's important to note here that physician advisors and coders are two separate groups. These are completely different scopes. Physician advisors are not coders. However, coders often can benefit from having a medical expert to discuss the reasons for certain decisions on cases so that they're more enabled to select the best possible code for every case on their desk. So it can be a physician advisor who provides that rationale to them. Physician advisors may also do peer-to-peers, and as we already mentioned, they may be expert witnesses at ALJ hearings. So what is a day in the life of a physician advisor like? Well, we tended to divide physician advisors into two groups, on-site and off-site. So for our on-site colleagues, they may start the day by rounding with teams. They'll discuss cases, patients who are currently admitted, with the attendings and with case managers. They educate both providers and non-providers on regulatory and compliance requirements. And these are always changing due to elections, global events, legislative changes. And so education is a huge part of the scope of a physician advisor's job. They will ensure that proper documentation is on each chart before that patient is discharged, either by following behind the attending or by discussing with them before they're finished documenting. They write letters recommending the appropriate level of care, and they may perform peer-to-peers with insurance company medical directors on behalf of the clinical physicians. For our off-site colleagues, they will evaluate cases by phone or electronically. They provide status recommendations via those same modes. They'll write letters of recommendation or appeal. They may lead remote meetings with physicians and medical staff to educate on regulatory compliance and documentation requirements because, as we said, they are always changing. They'll need to be available by phone for physician or staff consults. They too may communicate with payers for peer-to-peers or appeals issues, and they may represent client hospitals at ALJs. But just as important as what a physician advisor does do is what they do not do. And what they do not do is provide diagnostic or treatment recommendations, criticize ongoing care, or have direct responsibility for patient care. So you may be wondering, particularly if you've never had personal experience with a physician advisor, does any of this really make a difference? And physician advising as a field has been around for long enough at this point, over a quarter century, that we have data and can draw some conclusions. And one thing that we are able to see is that improving compliance and streamlining documentation, which are two things that physician advisors absolutely do, directly lead to an improvement in quality of care. And that's because they help optimize lengths of stay, they decrease medical errors, and they reduce the number of times that physicians have to return to the chart. Physician advisors also help prevent or correct inaccurate reimbursements, and that ensures that resources remain available to serve the community. That can be especially important for small local community hospitals. So being a physician advisor means that you're leveraging your previous hands-on experience in a new but equally important way. So what are some of the typical requirements for the position of a physician advisor? Well, from a clinical perspective, an MD or DO is required, as well as an active unrestricted medical license. Board certification in your specialty is preferred, 5 or more years of clinical experience, and a high level of comfort reviewing cases across specialties. It is very rare that a physician advisor would review cases only in their own specialty. So the faster you can have a comfort level or create a baseline knowledge of most specialties, the better it'll be. From a non-clinical perspective, written and verbal communication skills will be key for this role, as well as the ability to very quickly gather and combine information and make rapid, excellent decisions with that information. Being a strong clinician, having excellent interpersonal skills, being at the same time a great team player and a confident leader, being able to strike that balance, as well as being computer proficient, typing at least 30 words per minute, but practically speaking, probably faster. And if you're offsite, having secure high-speed internet connectivity at home. Now, some of the physician advisor companies out there, this too is not an exhaustive list because this list is always changing. New companies come on the market, old companies merge. But at the time of this recording, some of the big names in the field are Medmetrics, Cora Clinical, Exelis, R1, Edify, Sound, Optum, and Apprise MD. So these companies' websites, as well as LinkedIn, are your best friend when it comes to letting you know who's hiring at any one given time and who currently employs people that you know, your current colleagues or former colleagues, as their employees. So one question I always get when discussing physician advising is whether this job can be done part-time. And the answer is yes. There are several ways that that can happen. If you're off-site, you will only take cases during your scheduled shifts. So you can negotiate with your employer to take only a certain number of shifts per week or per month. If you're on-site, smaller hospitals may only need you a few days a week. And there's also the possibility of job sharing. If you know someone else who wants to work part-time, you may be able to split a full-time job. So the fun stuff to talk about is always the benefits. What are the pros of this kind of job? Well, if you work offsite, you will never have to worry about traffic again. I live in the greater DC area, which has the dubious distinction of having the second worst traffic in the United States. So I did not regret hanging up my driving shoes. I do not miss rush hour, and you won't have to either. You don't have to worry about call. You no longer need malpractice insurance, and you have the opportunity to learn a new subspecialty. Most of us in medicine really enjoy learning, and this is an area that very few of us had exposure to in medical school or residency training. So the opportunity to learn something completely new without another residency is really exciting. You have the chance to collaborate with numerous other physicians on a daily basis all over the country. Depending on where your employer's client hospitals are located, they could be in any of the 50 states. And that's not even including your own teammates who, if you're remote, they too may be in any or all of the other 50 states. So it's your chance really to get to know different hospital systems, be familiar with different EMRs, learn about geographic disease and treatment trends, all of which is really fascinating. You'll have the chance to improve your regulatory and clinical knowledge base, which, as we mentioned, very few of us had exposure to during our education and training. And it's especially exciting because this is an area that, for many physicians, is fairly obscure. And you'll enjoy a reasonable work-life balance. You gain exposure to hospitals and health systems nationwide. Information is always a good thing. The compensation, benefits, and bonuses in this field are competitive. And you'll apply your established clinical experience in a different way. And you have the satisfaction of knowing that you're helping your fellow physicians in the process. And this probably is the biggest benefit to me personally, the thing that I enjoy the most. But of course, we have to talk about the drawbacks. What are the pros? I mean, sorry, what are the cons? We just went over the pros. But what are the negatives to being in this field? Well, one is that the training process can be intensive because, as we mentioned, many of us have very little exposure to this before we become physician advisors. There's a lot to learn. And so training can be on site out of state for several weeks, and training will continue even after you return home because there is so much to know. Because the legislative landscape is always changing, much of that learning is self-guided. You can't rely, especially if your employer is a large, somewhat small, slow-moving company, you can't rely on them to always be on top of it. It's something that will have to be a personal motivation. And it's a fast-paced environment, which can be overwhelming at times. Physician advising is fast-paced in a different way than clinical medicine is fast-paced, and that does take some getting used to. Because patients are admitted to hospitals 24 hours a day, 7 days a week, some physician advisor duties are 24 hours a day, 7 days a week, depending on your employer's contracts with their client hospitals. So some weekend and holiday hours may be necessary. Team meetings are crucial because things are always changing, and they can occur outside of your scheduled hours or outside of your time zone based on where your teammates may be located. As well, managing client relationships can be challenging. This is less of an issue now than it was 10 years ago, but even now we will sometimes encounter attendings who have had no experience with physician advisors and whose default is to assume that we're the enemy. So it takes time to build trust and to help them to understand what our role is and that we're here to support them. And also, like all consultants, sometimes you'll recommend things that the attending does not want to hear or doesn't agree with. So that takes some finessing and it can be a challenge. As well, if you work remotely, you'll need to worry about ergonomics. You will have to put some money into your home office to arrange it so that you're protecting your spinal health, your vision, etc. Power outages become an issue. If you work outside of the house, a power outage at home during the workday doesn't really make that much difference. But if you work from home, a power outage can be the difference between working that day or not working that day. And it can put a huge burden on your teammates. So this is something to be aware of. As well, dependent care is still necessary. Physician advising is not the kind of job you can do and expect to watch your small children or your elderly family members. The last thing you want to do is to be on an official call with a judge and hear the strains of the Cocomelon theme song in the background. It is important to remember that dependent care, you cannot fire your nanny or your daycare. You'll still need them. And establishing relationships with other remote physician colleagues, it'll take effort. If you're no longer working in person with your colleagues, there's no more water cooler time, there's no more grabbing lunch in the cafeteria. If you live in different states, you can't even meet after work. So it's very doable, but it's something that now will require initiative and it has to be a personal goal. It's not something you can rely on happening organically. And then there are the things you need to consider when you're moving into any form of non-clinical medicine, not just physician advising. If it's your first time leaving clinical medicine, then you may have to face a potential change in self-identity as a doctor. But it's important to recognize that just because you're no longer seeing patients doesn't mean that you're not still using your education and training. American healthcare, as it stands today, very much relies on physician advisors. It's a critical role that's just as important, it's just different. And keeping your clinical skills fresh, if you want to continue practicing clinical medicine while working in non-clinical medicine, that will take initiative. It takes a plan. It's something that you have to make sure you're taking steps towards. So what if you've decided that you might want to pursue a career as a physician advisor? What are the steps that you'll need to take? Well, firstly, you'll need to read. You really cannot read too much. Not only will you want to brush up on your own specialty, but you'll also want to go back and review diagnoses and treatment plans for things that you might not have seen since medical school. The faster you can become comfortable with other specialties, as we mentioned before, the better. You may want to join the American College of Physician Advisors, ACPA, in order to take advantage of their library of learning resources and to network with others. You can consider attending their annual conference, NPAC. You'll want to use the application and interview process to showcase your communication skills and professionalism, two traits that are absolutely imperative in physician advising. And stay confident. Remember that you're an expert, but at the same time, be respectful of other physicians. For many of you, this may be the first time as an attending that you're no longer in charge of the patient's care. So it's important to remember that. And always stay positive. Like whether you're a physician or an accountant or an underwater basket weaver, everybody wants the person with the smile on their face on their team over the person who has a complaint every hour. So keep that in mind and always focus on your positivity. There are also board certifications available. Healthcare Quality and Management offers one, ACPA offers another. There's also an advanced certification. And these may be further down the road, but they're good things to keep in the back of your mind and to have an idea of working towards if that's your goal. So who am I and how did I get here? Really briefly, my story began with a bachelor's degree in broadcast journalism, which gave me the opportunity to have a lot of really wonderful experiences. I was able to intern at the White House, at CNN with Dr. Sanjay Gupta, at Warner Brothers in Hollywood. And after that, I went to medical school, did a PM&R residency, was board certified in PM&R. And as an attending, I worked in both the VA system and private practice. But as the years went on, I was looking for a way to incorporate more of my communications background and experience into my medical career. So I attended SEEK in 2011, and I became a physician advisor in early 2012. And I've been fully in the world ever since. I've never looked back, and I can honestly say that I have enjoyed almost every moment of it. So thank you so much for joining me today. If you have any questions, please feel free to reach out. And I really hope that I'll have the opportunity to cross paths with some of you as colleagues in the future. Thanks so much.
Thank you so much, Doctor. I'm going to stand in for some questions if you don't mind.
Absolutely.
Um, so I know this probably varies, but any sense, ballpark, how many cases, issues you would deal with in say an hour and say a shift? It would be hard to express. Like, what's kind of your volume? Is it like 50 items a day or more like 15?
Right. No, that's a great question. And it really depends on your employer and their proprietary system. But I would say that it probably varies anywhere from 2 to 6 cases an hour, depending on multiple other factors. But I think that's a good ballpark. And of course, some cases are more complex than others. That's just life. That's the way it's going to be. But in general, it would average out to about that amount, depending on whether you're accessing the EMRs individually, whether they're being funneled through an overarching system, that kind of thing. And so, some days will be faster and more crazy than others, but that's a general average.
And uh, how prevalent are these jobs? Are there like a lot of these jobs out there? There's always going to be openings. Can you give a sense of that, Doctor?
Yeah, and that is something that undulates a little bit. It does flex depending on where medical budgets are being directed. So for a while, everyone was outsourcing physician advising, and in that case, there was a sort of a glut of jobs. And then there came a phase where hospitals were starting to move it in-house, in which case they really only needed a handful of physician advisors. So I would say that at this point, there are, as you know, my previous slide showed, there are several companies that are almost always have several of them hiring. So it's certainly something where you can expect there to be job openings at any time, but whether they will be job openings that require you to be on site and therefore will be need to be somewhat near your home, or job openings that will be remote and therefore you may have access to more of them, that kind of comes and goes.
And in terms of the market, like today, do you have a sense as to what percentage of the jobs are in-house versus contract on site?
I I don't have a solid number for that, but I would say right now that I would say there are more remote than on-site jobs. I'm not sure I could give you a number. I don't really have that information, but just anecdotally speaking to what I see that I'd say there are probably for maybe every one on-site job there are two remotes. That's just my experience. I don't necessarily know that that's true of the market as a whole.
And you mentioned, if you're off-site, I guess the hospital could be anywhere. Do you need a license wherever the hospital is, or is that not an issue?
No, you just need one license in one of the 50 states, which is really fantastic. Now, there are some very niche exceptions to that, which won't apply to most people, but there are some very specific payers that require someone, for example, with a California license to work on California cases with a very specific sub-payer. But your employer will kind of handle that and find one or two people who are already on the team who have the relevant license and funnel those cases specifically to them. It's not a common enough issue that most people need to worry about it.
So you're obviously a people person, and a communicator, like to communicate verbally and things like that. What percentage of your job is typically, bookwormy, not bookwormy stuff, but you're reviewing records and you're doing alone stuff versus actually being out there talking to people?
Yeah, it depends too on your role, but I would say on average it's 50-50. So there is a lot of record review, which I personally enjoy. It's kind of like research back in our student days. It's really interesting and it's also a little bit of detective work. It's you're finding the one or two factors in that patient's case that help make your case. If we're going to pretend we're attorneys for a second. If you're making a case for why this patient should be inpatient or should be observation, you're looking for the couple of pieces of data in that EMR that will support your case. And those pieces of information might not be very obvious. You might have to go down into dusty corners to find them. So I really enjoy that. Then the other 50% is talking to either staff members at the hospital, talking to them about the case, talking to them about deficiencies in the case, or talking to payers, arguing your case about why a status should be one way or the other, arguing your case before a judge about why an appeal should be overturned or a denial should be overturned, or discussing with them what other pieces of information they might be missing from the client hospital.
Every time I ask you a question, you make me think of a different question. I'm sorry, doctor, I'm making you work here. So
No.
payers, you mentioned payers, doctor. So I would imagine that you're interacting with counterparts in utilization review as the payers. Um, Obviously, a lot of the same skills that you would use in your job would be used on the payer side. Is there job mobility, and have you known people to go over to the insurance side of things, the payer side, after being a physician advisor?
Yes, definitely. Both it goes both ways. Absolutely. We have for sure had colleagues go to the insurance side and had many, many insurance medical directors come over to our side. So I mean, you do find that the experience on both sides will help you. I'm sure this is true. Again, in law, I'm sure it's true. If you're on defense, I'm sure that helps you when you're defending, when you're working for plaintiffs and vice versa. And I think that that principle applies here a little bit as well, but you definitely see a lot of people going back and forth. For me, I really enjoy the physician advising side and working for the healthcare system, working for my fellow physicians and their patients. So I've always just really found that to be a great thing.
So you mentioned that, I mean, I guess probably not usually, but sometimes you have to be coverage in the evenings and on weekends and things like that if you have a shift. But is these typically around the 40-hour-a-week job, give or take, if you're working
Yes.
overtime?
Oh, yes. And if you're part-time, you would negotiate less than that. So, and there are definitely people who have somewhere in between, 32 hours a week or some other, sort of random number. So yes, for sure. And in my experience, you can certainly work more and pick up more shifts if you want to, but these are generally 32 to 40 hours a week.
And fair to say that you know your schedule weeks or months out, so none of this call stuff and none of this will, we're bringing you in. You can have a life and plan your life. Is that fair?
Exactly. That's actually one of the biggest benefits of this position is just the amount of control that you get back over your life.
And obviously, we're going to talk about your side gigs in a bit, but time for side gigs, correct?
Yes, exactly. I mean, I know so many people who are involved in incredible side gigs, some of which have nothing to do with medicine, but they're artists or they're coaches of teams and things, and so they sort of had the chance to give a little bit more of themselves to this other endeavor that they might have had to bury for their many years in clinical medicine. So that's another real benefit of physician advising.
All right. So in addition to this role, in addition to your podcast, you're a mom. And have you found, in your experience, the remote jobs to be flexible in the sense that I want to pick up my kids at school every day, so I don't have to take the bus. Is that something that you might be able to work out, or is it more like I got to lock myself in a dungeon for 8 hours and I come out at 5 o'clock?
No, I think it's much more the former than the latter. I think there is a little bit of a tendency sometimes to think of remote jobs as being completely free and easy, and that is not the case. I mean, you are really expected to be there for your scheduled hours. But that being said, for the most part, your teammates also understand that things come up and, people want to be flexible for each other. And so certainly if there is something that you need to be there for your kids or other family members, I have found that that has 99% of the time you're able to do that. You can work that out with your colleagues. You can, if it's something that's recurring, you can just work that into your schedule from the beginning. People are very understanding of emergencies and things that pop up. People are very understanding of needing to step away for 15 minutes because something that's not an emergency came up. Again, of course, you don't want to take advantage of that, right? I think that's true in any job. But the flexibility is certainly much, much more than that of clinical medicine that you can't deny.
All right, now I got to be cross-examined a little bit. So you said your earning potential, I think the word you used is competitive. So compare it to like what a primary care physician would make to start. Are we talking around the same, a little bit more? Any
Yeah,
sense, doctor?
a little bit more. I'd say probably about 20 to 30% more than starting salary for a primary care physician. I think for a highly specialized surgeon, it's going to be significantly less. So you're really then at that point thinking about whether the work-life balance is making up for that financial change. But for a lot of physicians, they're going to be very pleasantly surprised to see that they're making notably more than what they might have been making clinically.
More money for less work. I like that formula. Okay.
Or less stress, at least.
Well, there you go. It's less hours and less stress. Specialties preferred, if any, or specialties not preferred?
I would not say there are no specialties that are not preferred because physicians in general are able to get back into that mindset of learning about all specialties. You just have to go back to the idea of being in medical school. But specialties that are more preferred, different companies have different needs, but I'd say in general, primary care is very highly valued just because that is more general. Of course, I am not a generalist. I'm a specialist. I'm a rehab physician, and that has its own benefits because there are specialized services that require physician advisor input. As I had mentioned, inpatient rehab, inpatient psych is another one. So you may find that if you're a even if you're a specialist, there is actually a niche for you, which is what I was very grateful to find for myself. But yeah, primary care is very highly valued, but it doesn't mean that that's all anybody wants. As long as you can demonstrate that you are open to learning, that you're willing to read, I really think that most companies will at least give you a chance and consider you.
So one of the things that professionals really like about their work is that it's not really so much the prestige, but the intellectual stimulation, the intellectual challenge of it. On a scale from 1 to 10, with 10 being the most intellectually stimulating, where would you rate these roles?
For me, 9. And the reason is because I just enjoy that every day I have no idea what case is going to come up. It's so fascinating. Like it could be anything from a NICU baby to someone going through alcohol detox to someone in florid hepatic failure. Like, and all of these things, especially as a specialist, they were not things that I saw on a daily basis. My panel was so much more narrow, which has its own benefits clinically. But non-clinically, I've just really enjoyed the chance to, read up on some diagnosis I literally had not seen since medical school. And every day, any day that could happen, which I find really exciting.
And you mentioned some doctors continuing the practice. Did you or do you continue to see patients on the side?
I do not anymore. But I have plenty of colleagues who do, and I have plenty of colleagues who don't. So really, either way, whichever you choose, you'll be in good company. No one will think it's odd. There's definitely a place for you.
Any issues or challenging maintaining your license or boards not seeing patients?
Not so far as I've had. I'm licensed in 2 states, in Maryland and North Carolina. And as long as you keep up your CME requirements, every state has their own requirements. There's CME requirements and annual fee, et cetera, that kind of thing. It has not been a problem. If you were to return to clinical medicine, every state has their own requirements for that. So some states do say if you have been, let's say, out of clinical medicine for 48 months, then they require you to shadow someone before you can return. So that is something that if you think you'll return to clinical medicine in the future, either you need to be very clear on what your state's requirements are for reentry, or you need to keep a hand in clinical medicine all along. So volunteer at a free clinic or take one shift a month or whatever you need to do. So it has to be either or if you think you'll return.
And in terms of your boards, have you had to recertify doctors since you've been doing this?
I have, yes.
And how much of a pain in the neck was that not being in the field?
None really, especially because boards now and almost all specialties are really moving towards rolling certification. There are very few now, I think, that are still doing the big exam every 10 years, which is
Okay.
what it was when I first graduated. But now, because we're doing rolling certification and because non-clinical medicine is becoming every year more and more common, boards are no longer kind of just like shell-shocked by the idea. Every year it becomes a little more familiar. They start to have a few more options for non-clinical physicians. So I haven't found it to be a challenge at all. I just do my quarterly questions. I keep up with all the requirements, the projects, the fees, and everything. And as long as you do that, and they know that I'm non-clinical, it's not a problem.
Do employers give you time for and pay for the CME? And do they give you time for and pay for the boards and the licenses?
Yes, depending on your employer, and also depending if you're salaried or a 1099. But yes, in general, salaried, if you're a W-2 employee, especially if you're full-time, almost always those will be covered. If you're part-time, sometimes they'll be covered. Depends on your contract. But yes.
All right, now the fun question. Can you tell the audience a little bit more about your podcast? Because they might be interested in that.
Sure, I'd be glad to. Well, I'm the co-host of a health and parenting podcast called Health and Home with the Hippocratic Hosts. I host it with my longtime friend who is also a board certified physician. She's a pediatrician. And we cover any topic under the sun that has relation to health or to raising great kids. We've had such a fun time. We've had an amazing array of experts on the show that we get to chat with, learn from. We talk about our own experiences in medicine. We do sub-series. We did an excellent sub-series on mothers in politics, where we've interviewed various women who've been elected to office around the country. And it's just been really exciting and a fun way to, yeah, use more of my communication background and that kind of thing. But also, it's been a fun time for me in terms of learning more about how to be a better parent and just a better citizen of the world. Because, health affects us all, whether you're a parent or not. Anything having to do with medical news, medical breakthroughs, they're all going to affect us in one way or another. And we're just really thrilled to be a trusted voice in that community that people can come to learn and to have a good time doing it.
Thank you very much, Dr. Varghese Kroll. You are a bundle of energy, as always.
Thank you, Jim. Pleasure as always.